Good morning. I'm Dr. Helene Clayton-Jeter. I'm a health program coordinator in the Commissioner's Office at the Food and Drug Administration. I am the director of the Cardiovascular and Endocrine Liaison Program. And it's my privilege to moderate this session today. I have on the stage with me three distinguished gentlemen. The first presentation will be by Dr. Ola Akinboboye. You have his bio in your folder, so I won't go over all of his great accomplishments, but I will give you a brief indication of some of the things that he's done and who he's affiliated with. He's an associate professor of clinical medicine at the Weill Medical College of Cornell University, New York. He is also the medical director of Laurelton Heart Specialists in Laurelton, Queens, New York. He is past president of the American Association of Black Cardiologists. He was recognized by New York Magazine as one of New York's best heart doctors. This was in 2006 through 2008. And on the cover of the Network Journal for 2008 as one of the best Black doctors in the New York in-state area. His presentation today is an update on cholesterol management. It's the 2013 American College of Cardiology and the American Heart Association guidelines. Dr. Akinboboye, come on up.
Thank you. Thank you so much. Well, good morning. It's a pleasure to speak on this topic of update on cholesterol management, looking at the 2013 ACC-AHA guidelines. These are my disclosures. I don't believe that I have any conflict of interest. I speak for a few companies, and I don't think any of these relationships will impact what I'll be saying today. Well, what I thought might be helpful, at least in terms of providing a springboard for my story this morning, is to take a quick moment to sort of look at the history of lipid guidelines over the past couple of decades in this country. Now, as you all know, we had the first adult treatment panel 1 guidelines, which came out in 1985. Then we had ATP2 and then ATP3, which came out with the update in 2004. And if you look at all of these guidelines, what is clear is there is a common thread in the sense that they are all LDL-centric guidelines. The core concept seems to be that the LDL level of the LDL levels is assumed to determine the level of cardiovascular risk, and LDL is the primary target of therapy. So that has been the main thread that runs through all of these ATP guidelines. Now, ATP4 panel was put together by the NHLBI to update the third panel's recommendations. But then shortly after that, the NHLBI decided to get out of the business of doing guidelines. And then the ATP4 panel then became the blood cholesterol expert panel under the auspices of the ACC and the AHA. And from the outset, this panel made a decision to focus mainly on randomized clinical trials and meta-analysis of randomized clinical trials, and to limit the number of expert opinions. Now, if most all the recommendations that came through from ATP1 to ATP2 and ATP3 are basically based, for the most part, on the results of all these statin studies. And when you look at all of these statin studies, I mean, we have a lot of them now, and both in terms of primary prevention and secondary prevention, you see that many of these studies, I mean, actually all of these studies, basically randomize patients to treatment either with statin or with placebo. A few of them randomized some patients to high-dose statin versus low-dose statin, but almost all of them randomized patients to treatment with a statin versus placebo, or a high-dose statin against low-dose statin. Now, so the key point here is that the randomized intervention in these trials was actually statin use, not LDL levels. So to now take a leap from studies that basically looked at the randomized patients to different statins against placebo to come up with guidelines that apportion specific risk to specific LDL levels is actually quite a big leap of faith, because you're going to have to assume that all of the benefits that accrue from using statins are predominantly or primarily driven by their impact on LDL levels. We know that is not true because we know of so many lipid-independent effects of statins. I don't want to list all of them, name all of them. You have increased synthesis of nitric oxide, reduced production of metalloproteinases, a lot of impact on platelets, fibrinogen, reducing blood viscosity. So there are so many things that statins do. So to just take all of this data and just say, well, everything that we're getting as benefits from using statins accrue from simply lowering LDL is a bit of an overreach. So the challenge then with the old guidelines of treating to a specific LDL target include the following. One, the current randomized clinical data do not indicate what the target should be. We don't know the magnitude of additional CVD risk reduction that we get with one target versus another. We don't know the rate of additional adverse effects from multi-drug therapy used to achieve a specific goal. Because right now what we tend to do in our practices is patients try to bring their LDL down to a specific goal. Some do it with statins, some do it with drugs like ezetimibe, some do it with drugs with natural supplements. And we don't really know what the impact of all of these multi-drug treatments that are targeted on trying to achieve a specific goal, we don't know what their effects will be in terms of adverse reactions. So we don't clearly understand then the net benefit of this whole concept of treating patients to a specific target. So I guess based on all of these issues, the committee decided to take a wrecking ball to this LDL house of cards and say, maybe this is time to just fess up that we don't really have enough evidence to back all these recommendations we've been making about specific LDL targets. If you have 2 or more risk factors, 130, if you have 1 or less, but 160, we don't really have that evidence. So they started completely on a new path, which is for us to identify people who will benefit from statin treatment. Now, they identified 4 groups. The first will be patients with clinical CVD. Those are, and I will define that subsequently. Patients with super high LDL, that is LDL more than 190. Diabetic patients between the ages of 40 and 75 with LDL between 70 and 189. And others between the ages of 40 and 75, LDL between 70 and 189, and 10-year CVD risk of equal to or more than 7.5%. Now, these all, of course, pertain to patients over the age of 21. They also identify 2 groups of patients who will not benefit from statins. These are patients with heart failure, classes 2 to 4, and patients who are on dialysis. Of course, the news media have been having a field day with these guidelines since they came out. Here is Brian McFadden with his New York Times. You check your pulse. If you have one, you should be taking statins. Well, if you look at the algorithm that they came up with, if you're over the age of 21, the first thing to do is to screen for CVD risk factors and then measure LDL. And if there is existing evidence of arterial CVD, then right away they go down the track of high-dose statin, and I will define that in the next slide. Then if you have diabetes, either type 1 or type 2, and you're between 40 and 75, LDL between 70 and 189, again, you need to be on a statin. But to determine the intensity of the statin treatment, you need to calculate the 10-year risk. If the 10-year risk is 7.5% or more, that will be a patient that you want to put on high-dose statin. If it's less than 7.5, you want to put that patient on moderate-dose statin. Now, if there is no diabetes and patient is between 40 and 75, LDL is between 70 and 189, you need to calculate the 10-year risk here to determine whether or not this patient should get on a statin. And if the 10-year risk is more than 7.5, then you have the option of either giving that patient moderate-dose statin or using high-dose statin. Now, in patients with LDL that are super high, that is more than 190, they go right down the track of high-dose statins. So how do you then gauge the intensity of statins? Well, high-dose statins will be any kind of treatment that will drop the LDL by more than or equal to 50%. Moderate dose will be those that will drop LDL between 30 to 50. And low dose, which is not recommended in the guidelines, will drop LDL below 30. So in the high dose category, you have Atorva at 40 milligrams or 80 milligrams. You also have Rosuva at 20 milligrams or 40 milligrams. Those two will help you achieve a drop of more than 50%. In the moderate dose category, you have options like Atorva, 10 to 20 milligrams, Rosuva, 5 to 10, Simva, 20 to 14, Prava, 40 milligrams, Lovastatin, 40 milligrams. And in the low, less than 30% reduction, your options are Simvastatin, 10 milligrams, Prava, 10 to 20, Lovastatin, 20 milligrams, Fluvastatin, 20 to 40. So these are the options that you have in terms of how you choose your statins. And the focus right now is really just statin treatment and statin intensity, not specific LDL levels. So then we now get to the issue of how do you calculate risk. Now, there are several algorithms that you can download on the internet. What I find quite helpful is this particular app, which I was able to buy in the App Store, or the so-called 99-cent store. I actually bought the app for 99 cents, believe it or not. It's clinicalc.com. And, you can do, it helps you with many of the calculations that we use in medicine. And one of them, of course, the one that you'd be interested in will be the one on the 10-year risk assessment equation. And you get something like this where, you need to put in the gender of the patient, the age of the patient, the race, and this is the first time on like ATP3 where we were using a risk profile derived from Framingham, which is a fairly homogeneous population. You actually have the opportunity here to do risk profiling using data, using race-based data. So this is this is a welcome development. Of course, you have to put in total cholesterol, HDL cholesterol, systolic blood pressure, indicate whether the patient is currently receiving treatment for high blood pressure, presence or absence of diabetes, and smoking. And then you hit calculate. And then it will give you the risk score right there. And it will actually tell you what you need to do to optimize that risk score and actually tell you what kind of statin treatment you should put the patient on. So this is what I do routinely when I see patients in my practice now. So how do you initiate statin therapy? Again, the first thing, let's take an example of the group with clinical CVD, cardiovascular disease, defined as acute coronary syndrome, history of myocardial infarction, either stable or unstable angina, or any prior revascularization, CVA, TIA, or PAD believed to be of atherosclerotic origin. And really, what you're expected to do is to start a discussion about CVD risk reduction, discuss adverse effects, drug-drug interactions, and explore patient preferences. So the idea of this guideline is not to force-feed everybody with statins, but to actually start the discussion. I mean, when you go through the whole process, the patient may elect not to be on a statin, but at least give them the opportunity to know what is available to them in terms of reducing their risk. And of course, the guidelines are very heavy on lifestyle. They strongly believe that lifestyle modification, adhering to a heart-healthy diet, regular exercise, avoidance of tobacco products, and maintenance of a healthy weight remains a critical component of health promotion and CVD risk reduction, both prior to and in concert with the use of cholesterol-lowering drugs. So the guidelines strongly emphasize modifying the risk factors of these patients. So let's do a couple of case vignettes. Now, here's a 45-year-old white female who is a malpractice attorney. No prior history of CVD. The father died at the age of 52 from a massive heart attack. No other risk factor. BP is 140/70. Now, when you look at the lipid profile, total cholesterol is 275, LDL is 188, HDL 52, triglycerides 175. So let's quickly look through the four big groups. Clearly, she does not have CVD already, so she doesn't qualify based on that. She does not have super high LDL. LDL is, although it's very high, it's less than 190. Now, she does not have diabetes, so you're left with the other group. She's between 40 and 75, so she fits in right there. LDL is between 70 and 189, so she fits in there. But when you calculate, now by show of hands, who would like to give a statin to this patient? Yeah, I see a good number of you will want to do that. But when you actually look at calculate the risk score, it's only 1.8%. So if you're going by the four standard groups, you're going to say that this patient does not qualify for statin therapy. But based on this history with an LDL of 188 and a very strong family history, I will be concerned. And actually, the guidelines made some provisions for that. There are going to be some people that you're going to consider for statins, even though they do not qualify, they do not fit those four standard groups. Now, these are patients with LDL of more than or equal to 160 or other evidence of genetic hyperlipidemia, patients with strong family history of coronary artery disease, CRP of more than 2, calcium score of more than 300, ankle brachial index of less than 0.9, or elevated lifetime risk of CVD. So clearly this lady fits in here with an LDL that's more than 160 and strong family history of cardiovascular disease. So what are we going to see more of with these new guidelines? Well, we're going to see more patients on statins based on this paper by Pensina, which was recently published. We're going to see the number of people on statins will go up from the present number of 43 million to 56 million. And 10 out of this 13 million increase will be mainly for primary prevention. Well, we're going to see more statin intolerance. Again, the guidelines do not advocate what we tend to do right now, which is, well, start at Tova at 10 milligrams, then go up to 20, or start Simva at 10, go to 20. No, they want you to start at specific points. Of course, and with that, you're going to have more patients coming in with complaints of muscle pain, muscle tenderness, muscle fatigue. We're going to use few drugs to treat patients with very high LDL. Right now, patients with very high LDL, we give them statins, we give some of them ezetimibe, some of them even take natural supplements on top of that in an effort to get them down to goal. We're not going to be able to do that anymore. The guidelines just say put them on statin, and you don't have to really worry if they don't get all the way down to 100 or down to 130. So another strip by Brian McFadden, that maybe when we go to our hot dog stands, we should have statin as one of the condiments. You have your ketchup, mustard, and you have right next to you have your statin right there. So let's do one more case vignette. Now, here is a 68-year-old African-American male, no history of CVD, completely asymptomatic, no modifiable risk factor for coronary artery disease. That is, no diabetes, no high blood pressure. Now, total cholesterol is 162, LDL is 79, HDL is 52, triglyceride is 156. Now, by a show of hands, who will want to give a statin to this patient? LDL is 79, total cholesterol of 162. Who will want to do that? Anybody? Going once? You will? I see people doing that. Well, you know, when you actually look at the 10-year risk, it's 11%. So, you know, that is a challenge. I agree with you all. I mean, I will have a lot of problems giving this kind of a patient statins with a total cholesterol of only 162 and an LDL of 79. So, you know, this is a work in progress. I think right now the guidelines they may be too age dependent right now. The whole concept of treating risk using 7.5% as the cutoff has not been validated. We need some studies to validate that. We do know there is residual on-statin risk. If you look at all the statin studies, both primary prevention and secondary prevention, in the arms, in the active treatment arm, you still see residual risks that vary from 9% to 20%. Now, when we are saying that we only use statins, what do we do about that residual risk? I think we still need to answer that question. And of course, HDL is completely ignored. We know we don't know what to do with HDL right now. We know it's important. We just don't know what to do with it. So they chose to ignore it. So the key points to wrap up this, my final slide, when you're looking at patients trying to use the lipid guidelines, you want to assess them basically based on, it's a kind of a risk indication-based guideline. You're looking mainly at patients with documented CVD, LDL of more than 190, or diabetics with age between 40 and 75, or a 10-year risk of more than 7.5%. Patients should be at least 21 and should be a candidate for starting treatment. You clearly don't want to use it in patients with class 2 to 4 heart failure or those who are on dialysis because the data seem to suggest that they may not get benefit. You want to assess the 10-year pooled risk. Again, lifestyle is always the first step. Again, you have the option of low-dose statin, moderate-dose statin, high-dose statin. Just to keep this simple, just think of low dose as Simva 10 milligrams, moderate dose at Atova 10 or Atova 20, and high dose at Atova 40 or Atova 80. The goal is the dose of statin, not LDL. That's the punchline, is getting the patient on dose of statin that is appropriate for them. And of course, when you have those situations like the female attorney I presented to you, you want to look at other risk modifiers or risk stratifiers like lifetime risk, calcium score, LDL of more than 160, family history, CRP of more than 2, ABI of less than 0.9. So with that, I will stop, and thank you for your attention.
Thank you so much. Next, we'll bring to the podium Dr. Michael Kim. Dr. Kim is a professor of medicine at the Warren Alpert Medical School of Brown University, and he serves as the director of the Arrhythmia Service for the Cardiovascular Institute of the Rhode Island, Michigan, and Newport Hospitals. He is also the director of the Electrophysiology Fellowship Program at Brown. He is a national expert in atrial fibrillation, disease management strategies, and in cardiovascular outcomes with a perspective on arrhythmias. His presentation today is Disparities in Atrial Fibrillation, focused on anticoagulation-related cardiovascular outcomes. Dr. Kim?
Minority Quality Forum for the invitation to speak. Ladies and gentlemen, fellow colleagues, these are my relevant disclosures. I'm going to be talking about atrial fibrillation and anticoagulation-related cardiovascular outcomes. This is the reality of atrial fibrillation today in the United States. Currently, there's about 6 to 7 million people in the U.S. with atrial fibrillation. If we were lucky, we would see epidemiologically on this blue line over time with increasing atrial fibrillation. Unfortunately, our population is having more diabetes, more hypertension, more heart failure, and we're going to see this yellow line. So we're going to see a lot of atrial fibrillation. So if you look at the cost to society, and this has been a scourge in Western nations in terms of atrial fibrillation, this is a managed care data set, and you'll see here what I want you to get out of it is the principal cost driver here is inpatient hospitalization. Now, if we look at a more common atrial fibrillation population, this is the Medicare age predominant crowd. If you take a propensity analysis and look at the what's called the nearest neighbor approach, so there's two groups, patients that are exactly alike in every detail with the exception that one group has atrial fibrillation and the other group does not. And what you find is the group with atrial fibrillation costs our society about $26 billion more than their kind of neighbor without atrial fibrillation. Now, the thing that's interesting is AFib accounts for about $6 billion in direct cost, but $10 billion of non-AF cardiovascular cost and $10 billion of non-cardiovascular costs. So AFib is tracking with maybe a marker that these patients are more sick and have more problems. So how do we manage atrial fibrillation? Well, we can restore sinus rhythm by cardioversion, control heart rate, which is called rate control, control heart rhythm, which is called rhythm control, reduction in stroke risk, quality of life, which is deemed a soft cardiovascular outcome, but one that's vitally important, as well as other harder cardiovascular outcomes, mortality, stroke, and hospitalizations. So the Agency for Healthcare Research and Quality, in terms of defining what I've been involved in as comparative effectiveness research and cardiovascular outcomes, is designed to inform healthcare decisions by providing evidence on the effectiveness, benefits, and harms of different treatment options. Now, the key for this presentation is where does this data come from? Well, randomized controlled trials, ideally, research reviews, meta-analysis, expert opinion, and other forms of data. And it's continually updated. Now, this is going to be interesting when you look at racial diversity about how sparse the data actually are. Now, what I like about comparative effectiveness are the two terms compare and effective. And that's what I want you to think about. So in atrial fibrillation, when we manage it, the classic disease management trial is the AFFIRM trial. And this looked at controlling rate versus controlling rhythm in the presence of warfarin anticoagulation. So as you can see, after a few years of follow-up, there was really no difference in mortality between the rate and the rhythm control arm. So this could be viewed as, well, you could use either of these approaches for patients. Now, if you look at it from a diversity standpoint, only about 10% of the patients enrolled in this classic disease management trial that everyone generally follows, only 10% were non-white, okay? So if you look at it, the overall survival, the mortality endpoint, which was the principal endpoint of the trial, really wasn't any different. However, you had more adverse events in the non-white groups. Now, the numbers are so small, and this is a post hoc analysis, but it makes you wonder, do all groups act the same when faced or given a therapy? So if you look at other outcomes in this AFib space, outcomes do matter, okay? There are limited outcomes data available, but if we look, non-whites have a greater risk for warfarin-related intracranial hemorrhage. So that's bleeding in your brain, which is the most feared complication of warfarin for stroke prevention of AF. If you look at hospitalizations for heart failure, black patients had less guideline-recommended warfarin prescribed. So that's interesting. So these are relatively new, is if you have incident AF or new AF diagnosed, there appears to be a higher sudden death rate in the black population versus the non-blacks. And the blacks tend to have more severe strokes than whites. So where do we go from here? Well, this is a catheter ablation of AF, okay? And what you see on this side, on the left, is atrial fibrillation. And as the ablation's going, they turn into regular rhythm. Okay, the reason I show this schematic is there's really no data whatsoever in terms of racial diversity of any significance in this therapy, which is growing by leaps and bounds and is being upgraded in the guidelines. One of my former fellows will be presenting at Heart Rhythm, I think, about 2 weeks from now, that blacks are offered this therapy less. Okay? And so I'll leave that because I don't want to open that door. He'll present that at Heart Rhythm, which will be out west in a couple weeks. So this is the most feared complication of atrial fibrillation. This is a ischemic or thromboembolic stroke. So we all know from decades of clinical trials that warfarin anticoagulation is effective for reducing the risk of stroke in patients with AF and stroke risk factors in the magnitude of probably over 60%. Okay? The time and therapeutic range is of critical importance, and I'll just point out the INR, which is a measurement of how we monitor warfarin between 2 and 3, okay, results in a good balance between lower risk of stroke and a lower risk of intracranial hemorrhage. Okay? So the current 2014 recommendation for risk factor scoring before you decide on an anticoagulant is based on this CHADS-VASC. There was a CHADS-2 score that was used prior to this, but I'm only going to show this because it's a point scoring system, and we choose all these factors, but you know, there really isn't any breakdown by diversity when you look at these scoring systems. Okay? So in general, if you have a CHADS-VASC now of greater than or equal to 2, it's recommended you get a blood thinner, whether it's warfarin or one of these novel anticoagulants. Okay? Now, there were 4 large trials, I'm not going to get into them, of these novel oral anticoagulants or target-specific oral anticoagulants. And these are basically alternatives to warfarin, which has been around for decades. And as you can see, these are very effective therapies in terms of ischemic stroke reduction, very dramatically, a lower rate of intracranial hemorrhage in comparison to warfarin, and overall, the bleeding profiles are relatively comparable and perhaps maybe even better. Now, why is this important? Well, you know, there are benefits to novel anticoagulants that may exist in the non-white population. And if you look at, also in general, that some patients are very reluctant to use warfarin, there might be a lowering of the stroke risk threshold for using anticoagulants. The reduction in intracranial hemorrhage is very significant, better outcomes, and ease of use of these newer blood thinners. Now, I'm going to present real quickly some excerpts of data that I worked on with Gary and colleagues at the National Minority Quality Forum. And this was presented recently at the American Heart meetings. And you know, the premise behind this is that warfarin is clearly effective, but it's underutilized. Okay? Now, the issue here is that the effectiveness of warfarin on stroke and outcomes has not really been stratified by patient diversity, despite the decades of evidence in terms of its benefit. So we wanted to look at the patterns of warfarin use in Medicare beneficiaries stratified by such diversity, looking at race and gender as well as the cardiovascular harder outcomes of stroke, hospitalization, and mortality. And the data are extracted from large, readily acceptable databases. I'll let you kind of peruse those. We created cohorts in several years and followed them longitudinally for about 4 to 5 years. Okay? Did standard statistical analyses looking at these outcomes over time. And this is kind of what you're going to see here is over time in these cohorts, you'll see overall an increasing use of warfarin. Okay, so that's evidence-based medicine being associated with a translation in overall increasing warfarin use in all the subgroups of diversity, white, black, Hispanic, and Asian. Okay, you'll also see within the stroke actual events over time that you will see decreasing rates of stroke associated with increasing rates of warfarin utilization. And these values were statistically significant. Now, if you break it into more detail, okay, and these are kind of statistical plots, and if you can see this thin white line, okay, everything to the left of that line means it's better, everything to the right of that line means it's worse. So if you look at the effect of warfarin on stroke, clearly beneficial, but what points out here is the blacks don't seem to do as well. They do markedly worse than the other subgroups in terms of patient diversity. Now the risk here, this was a CHADS-2 scoring system, and the more risk factors you get, the more risk of stroke you have. But this is what really stands out, is that the black patients did significantly worse. Now if you look at mortality, the same thing is the warfarin effect on mortality is very beneficial, but look at here again, the black population sticks out beyond this line, okay, statistically significant. They do much worse in terms of mortality, okay? Now, if you look at total hospitalizations, and this was calculated a little bit differently, but if you're using the white population as a reference, once again here, the black population does 26% worse. Okay, now why is that? I can only tell you the associations based on this data. I can't tell you exactly why, but this is very interesting. Now, what does this mean is, in summary, compared to whites, black patients were 40% more likely to have a stroke, even after adjusting for warfarin use. There's a significant reduction in mortality with the use of warfarin. However, blacks have a 25% higher mortality risk, even when adjusting for that warfarin use. Okay? So, in conclusion, warfarin utilization over this 10-year time span, along with the evidence-based medicine, has resulted in net clinical CV outcomes and benefits, reductions in stroke, all-cause mortality, and hospitalizations. However, it is clear that there are patient diversity-related outcomes differences, okay? And it appears that the black patients seem to have the worst outcomes. Now, this would be a big wake-up call that patient diversity really needs to be a focus in terms of AF-related cardiovascular outcomes research. Now, there's absolutely no controversy that anticoagulation in AF patients at risk for stroke should be prescribed. Okay, you can argue whether it's rate control, you could argue whether it's rhythm control, you can argue whether you should have an ablation, you can argue whether you should be cardioverted, but there really isn't much debate here about the efficacy of anticoagulation. But yet, cardiovascular specialists, including myself as one of them, if you look at the recent ACC cardiovascular care facts, we don't do so well. 57% prescription rate, okay? Not very good at all, okay? Now, I show you this slide. This is actually one of the warfarin trials, okay? And you see these various countries listed. And remember, I showed you that slide in time and therapeutic range. This is between 2 and 3, the INR. If you sit in that sweet spot, you're going to half your event rate, negative event rate, you're going to do better. Now, if you look at these countries, one of the people in this trial, I can't remember who, is quoted as saying, in medicine, geography is destiny. Why is that important? Well, what I want you to get out of this is that's true if you look at access to care, provider availability, and it's definitely true in the AF space, in stroke prevention, and the US. So where you live and your access can be your destiny. Okay? Now, this was the first novel oral anticoagulant approved, okay, 2010. Okay? And why am I showing you this slide? Well, if you look at the 3 current approved novel oral anticoagulants, this is the first one, dabigatran, rivaroxaban, then apixaban. There will soon be a 4th, most likely, is you cannot find the diversity data, the racial diversity data. It is in nowhere in terms of an easily accessible place. Okay? Only one of the 3 main papers in the New England Journal, you actually see them try, and this is with dabigatran. They note 12,000 plus patients of European or Arab or Caucasian descent, and 5433 other. Okay? That's it. Okay? So I don't like digging through FDA filing documents because they're very thick and very long. And so within hundreds of pages buried in small little tables, you'll find numbers. These are the percentages of black patients enrolled in the trial. 1.2%, 1.3%, 1.2%. Okay? Something to think about. Okay? And so where are we going to get this data? Okay? Ideally, you'd love to get them from those randomized controlled trials. Okay? But that obviously did not happen with the novel oral anticoagulants. Now, I show you this mini sentinel analysis. Okay? Why do I show you this? Not because I want to talk about bleeding adjudication with dabigatran, but a lot of cardiovascular medicine is becoming a data-driven science. Okay? And the data is not always going to come from randomized controlled trials. Okay? It's going to come from administrative claims databases centralized to institutions or groups of institutions, or the FDA's mini sentinel analysis. Okay? So there are going to be methodology adapted as we get millions and millions of patients on drugs that maybe we can look at racial diversity or other subgroups to garner more data. So racial disparities, they clearly exist. There are challenges in the anticoagulation of AF. Okay, if we talk about dosing, black patients tend to need more Coumadin. Asian patients tend to need less. Time and therapeutic range. There's evidence that it's more difficult. Think about that. If you're dosing, if you don't know about those dosing differences, or if you have access of care problems, it's going to be harder to stay in your therapeutic range. There's genotyping, okay? You've heard of personalized medicine and pharmacogenomics. There's a big concern in individuals that don't have access to care. Are you underdiagnosing these people, okay? So why is there less guideline-based prescription in ethnic groups? 85% of what happens in medicine is provider dependent. Okay? So that is a paradox with cardiovascular outcomes that we as providers have to deal with because we're not necessarily following evidence-based medicine all the time, and we seem to be doing worse in non-white patients. Okay? So if you look at the new therapies for blood thinners in AF, only less than 2% of these patients, blacks, were in these trials. Now, what are potential solutions? Well, there clearly, I think we have to recognize that there are differences in terms of racial differences in healthcare access, quality of care, and cardiovascular outcomes. And you have to address these if we're going to obtain more meaningful population health benefits, especially with the changing demographics that exist in the US. I'm going to stress education, education, education. Patient, public, provider, and scientific data from wherever it may come, whether it's clinical trials, administrative claims, databases, and stress that an inclusion of racial diversity is really necessary to address and reduce the burden of gaps in diagnosis and therapy. And the use of real-world data is something that, is that mini sentinel analysis and administrative claims. So I'm going to end here, and thank you.
Well, thank you, Dr. Kim. Before we go on to our next presenter, I want to add that the FDA addresses product use issues through the Sentinel program, like you mentioned, but also we have a national medical device post-market surveillance plan. And I think those are 2 tools that we're using to address product use issues. And I'm sure we'll have some questions later around that. Next, we'll bring to the podium Mr. Coltrane Stansbury. Mr. Stansbury currently serves as Senior Diversity Analyst in Johnson & Johnson's Office of Diversity and Inclusion. In that role, he manages a portfolio of projects and supports the company's global diversity strategy, including the Gateway to a Healthy Community initiative. He has spent the last 15 years working in the field of community and economic development, helping to empower families, residents, and businesses in some of the most distressed communities nationally. His presentation today is Gateway to a Health Community. These are your 2-year results. Mrs. Stansbury, come on up.
Good afternoon, everyone. Well, I'm happy to be back in front of you. Last year, we presented on the Gateway to Healthy Communities initiative, and this is an update on how we've been doing over the past 2 years, now in our 3rd year of operations. The Gateway to Healthy Communities initiative was founded under the premise that we could help address the idea of childhood obesity nationally, and that at Johnson & Johnson, we could do that by leveraging the capacity, the ability, the inroads with our stakeholders through the Office of Diversity and Inclusion, which is headed by our Chief Diversity Officer, Anthony Carter, who is here with us today. Under Anthony's leadership and executive sponsorship of Mike Allman, Johnson & Johnson set out to address childhood obesity through the Gateway to Healthy Communities initiative, through launching an initiative that would allow us to look at the most at-risk and where the disparity is most prevalent nationally. And with that in mind, we set out to address the unmet and underserved medical needs of these communities. We did that by creating a program that could do 3 things: be able to find ways through schools to find children that are most at need, to also find ways to leverage those school relationships with children to get into the homes where parents and guardians are also suffering with the same needs. And lastly, together with school and with family, be able to reach and address the whole community. And that this would really allow us to have a holistic approach that has real impact. Our program, the Gateway to Healthy Communities initiative, seeks to do 5 separate things. Number 1, to be an engaging program where we utilize real-time, on-the-ground presence to address the need of childhood obesity in classrooms. Our program, which is run through ActivityWorks, the tool on the ground, seeks to engage classrooms and students in particular in 10 to 12-minute activity breaks, allowing kids to open up themselves to those 10 minutes of exercise through an audio, visual, and kinesthetic protocol, where children are seeing and interacting with curriculum-based activity that allows them during their brain break to have the most optimal amount of muscle exercise and brain activity with oxygen-induced, inhibiting their ability to go forward in their classroom experience with focus and attention. That also allows the program to be scalable in that our relationships in schools in Atlanta, in Houston, in Philadelphia, and in Newark, New Jersey is scalable in that we have the right relationships both internal to Johnson & Johnson through leveraging our employee resource groups, and in the Office of Diversity and Inclusion, our relationships in these different cities and states, our ability to be scalable and to have community impact. Our impactfulness is the fact that children enjoy our program. The program is not just has the ability to have them moving as a part of a whole classroom experience, but they enjoy it. It's measurable in that our program has built into it the technology, thanks to our relationship with Microsoft, to be able to measure every 10-minute episode that children are doing in all of our target cities in real time, that we have data to the very day that individual classrooms are participating. And lastly, our program is sustainable in that Johnson & Johnson set up to say, how can we create a program where our relationships will allow us, long after our ability and capacity 1 year to another to affect lives can still remain. That impact is built by our ability to partner with school districts, with politicians and policymakers, and also our ability to have community action groups and groups within J&J to help support our program for the long term. The program ActivityWorks, the platform itself, as mentioned, gives children the ability to do these 10 to 12-minute activity breaks while in their classroom. We have engaged stakeholders in our ability to reach more children. Our implementation strategy includes communicating seamlessly with community, with school, and with classroom practitioners so that all are on board for the optimal support of children. Also, we track usage in our program, which is tracked automatically. Once you log on to our database and access our episodes, you're able to see in real time what the calories burned and the cardio minutes exercised are for your classroom. We cultivate learning, and that these activity works aren't just normal, regular exercise, but they immerse a child in an audio-visual experience that also is connected to a specific learning episode: math, science, history, etc. We also celebrate progress, and that when children reach the optimal goal of 4 times a week utilizing our program, which is our recommended goal for realizing fitness, focus, attention, and better behavior, we have built into our program the ability to celebrate those classrooms, those students, and those schools who commit to that four times a week recommendation. And that's done through our ability to give psychological rewards and incentives as well. We're impacting the community, and that we're creating a movement of movement where children are able to take these values home and impact their lives at home as well as in their community by sharing positive values and positive outcomes. And lastly, we report results, and that our results are able to be published on our website and in print for our stakeholders and our community relations to be able to have access and celebrate with us all the success of our program. Our partners through the Gateway to Healthy Communities initiative, chief among them is the National Minority Quality Forum, in that we really go out and set out initially every year in our program when we find ways to access the most at-risk communities, schools, and districts nationwide. The National Minority Quality Forum allows us access to disease maps or heat maps that gives us the most prevalent childhood obesity areas by zip code nationally, that then allow us to then follow that footprint around the nation to find ways to best track and implement our program over time. Our relationship with Microsoft, they've given us access through our partnership to their Azure platform, which allows us to have our program streamed live in each classroom that is available and registered to our program. This allows them to view our program on smart boards where children in multiple classroom settings can see, view, and interact with the program. We also, through our partnership with Microsoft, have been able to expand our program from kindergarten to 3rd grade and to 4th through 6th grade through their Xbox Connects platform. We have a relationship with the Robert Wood Johnson Foundation, which is allowing us to develop more partnerships inside of New Jersey into other cities beyond Newark, which will allow us to be in Trenton, the capital, as well as Camden, New Jersey, and New Brunswick. And Emory University, we launched this year a study, which is also finding ways to relate our program, which is helping kids stay fit and focused, to their performance actually in the classroom with testing. Bright Horizons, which is connected to our early childhood centers in New Jersey, we have a partnership to go lower than kindergarten that currently has gone from a pilot to being in 5 sites throughout the state. And lastly, with Save the Children, which is our first attempt through a pilot to be in our rural communities beyond the larger cities into rural Nevada and Tennessee. So how are the students performing? The data showed in year 1, we were able to reach over 25,000 children through our program in the target cities of Newark, New Jersey, Philadelphia, Houston, and Atlanta. Through being able to create a grassroots communication strategy where principals who bought in initially were able to, by word of mouth, spread to other classroom teachers within their district, we're able to expand our program one classroom, one school at a time. And through that grassroots effort, in year 2, we were able to reach almost 50,000 students. An expansion into New York City this year allowed us also to reach now in year 3, without being in the conclusion, to 75,000 students. The results in calories burned in year 1, over 61 million calories were burned. Through leveraging resources and our stakeholder relationships, in year 2 we reached 230 million calories being burned. Important to our program is our classroom penetration. Of all the classrooms that we register in the district, as you can imagine with social programs and affecting social change, not all classrooms that are registered are actually using the program. So we measure classroom penetration as a way of understanding how much of the market we're affecting. So with classroom penetration in year 1, which is the 2012 school year, we reached a little over 40% of the children who are actually registered, classrooms registered to use. 40% were actually using. That jumped in 2013 to almost 50%. If we were talking about a business venture, 50% of the market is excellent. And we use this as a gauge of our ability to know when we're being successful in our grassroots campaign to reach classrooms at the recommended rate of 4 times a week, but also as a gauge of when we're able to now bring the program somewhere else that's needed to start over in terms of finding new ventures, new classrooms, and new districts so that we can start with creating a penetration model. We survey teachers and principals in our existing districts to find out how our program is being received and where the best value and benefit in classrooms really is lying. Classroom teachers who were surveyed in 2012 and 13, you find it in the blue. There's improved physical endurance at 9%, almost 80%. There's a great benefit as well as in focus and attention and self-control. Also, the ability of recognizing the importance of exercise. Classroom teachers, through utilizing our program, have found 87% found the benefit. The yellow represents where classroom teachers are encouraged usage at 3 or more times a week. Those numbers jump significantly, with the idea that using the program more, there's a greater benefit over time. Principals also, although not the primary users of the program, also attest to the great benefit. Our program, as stated earlier, is really focused at being able to have at the primary focus classroom teachers and physical education teachers as the main and primary implementers. However, we've also expanded that relationship to include special education teachers, autistic teachers, bilingual teachers, librarians, as well as occupational therapists and physical therapists, have all implemented our program under special circumstances and in unique ways to find optimal benefits for children. Now, I'd also, in addition to all this great data, which is showing that our program is working in schools and in classrooms nationally, it's important to take time to look at some of the anecdotal stories of how our program is affecting lives. And I want to take the last few minutes of my presentation to introduce you to one such story. It is a classroom in Philadelphia at the Loesch Elementary School, headed by Ivan Vizengoff, a story of a child, Sam, who's autistic, that I think that you all will be impacted by.
Johnson & Johnson's Gateway to a Healthy Community, Healthier Kids program presents Sam's story. My name is Ivan Dizengoff, and I've been a teacher of students with autism at Lesh Elementary School for the last 2 years. I found that I really needed to get the kids interacting with each other. I really needed to get them focusing on things, and I wanted them to do some physical activity to get fit. So every day we would show this video about the wonders of the world. The students would exercise to it, and the students, they had their eyes glued to the screen. They were learning what was going on, and they were jumping around, they were sharing with each other, they were pointing out things to each other.
A lot of times the child will come in and they will not be able to interact at their best, and they will not be able to participate with an adult at their best if they're not very well regulated. My name is Helene, and I'm a licensed professional counselor. I work with individuals and families affected by autism.
One little boy in particular was focused a lot more than I realized, because I got an email from his mother and she showed me a picture of Lego buildings of the wonders of the world.
My personal experience with my own son, who one time came home from school and built some structures from Legos that I didn't recognize. I usually can tell where his structures come from, but these creations didn't seem like I've seen anything similar to what he's built. And when I asked him questions, he said that they were the wonders of the world. And when I took a closer look, I recognized the very famous buildings in the world, like the Taj Mahal and the Stonehenge and the Leaning Tower of Pisa, something that we did not discuss with him at home, but something that he's learned somewhere else and decided to bring it to life by building it with Legos. To pick up on that interest and to build communication on that, I presented him with the world map, and we put down the world map and we talked about different countries, and he knew exactly where to put the buildings and which country the Leaning Tower goes to and which country the Great Wall of China goes to. And I made a discovery about my son that, in fact, he knew more about geography than I thought he did. And I learned new things from it myself, which was a nice benefit.
So it was a great thing. It was a great thing for that little boy. His name was Sammy. Later, we started integrating in other videos, and different students started having different favorite ones. Sammy had some other interests that tied in, and they would become his favorites. He's involved in sports a lot, swimming and basketball and soccer and volleyball. He also was interested in healthy eating. And so one of the episodes was about healthy snacks. And he would get very involved in those. He loved chopping the carrots and such. And so that was one way that I found to get a lot of students meeting all my goals at once. They were focused on the content. They were interacting with each other. They were getting exercise. And when they started having different students liking different, having different favorite episodes, then that was an opportunity for the students to have to discuss which one should we watch today.
And it gave us a great opportunity to interact with each other, because that's something that a lot of parents of children with autism struggle with. But if you know what your child's strength is, you can definitely, it makes it easier to find a common topic of interest and build more interaction on that.
I wanted to say, just in conclusion, that when you look at these children, and we have dozens of autistic and special needs classrooms throughout our program, the important thing about this program is not just the data, it's the fact that we're impacting lives. And that the Gateway to Healthy Communities initiative is just that. It's a gateway for children just like Sam, who would otherwise see life and be able to communicate with the outside world through a small window, actually now have a gateway of individuals who are supportive, classroom teachers, principals, policymakers, and parents alike, who are allowing these children to come out of a world of darkness and despair and be able to immerse themselves in a lifetime of learning. Thank you so much.
Thank you. So the only thing between you in lunch as me right now, so I'll try to be as brief as possible. I just want to thank the wonderful, my wonderful guests that we have today. Their presentations were awesome. Unfortunately, we've run out of time, so we won't be able to take your questions from the mics, but they have all assured me that they will be around, so you can ask them questions individually on a one-on-one. And I guess today we learned about the new 2013 ACC and AHA guidelines, disparities in atrial fibrillation, and looking at anticoagulation-related CV outcomes. And we also learned about grassroots efforts of empowerment of the underserved communities. I want to thank you all for listening, and we'll see you around.